Genicleulicel, that's a CAR T cell. So, I mean, it's a tongue twister. So, we just call it a CAR T cell therapy. And then, of course, we've got all the imatinibs, esatinib, and the whole monoclonals coming through. Brentuximab vedotin. So, it's really, I mean, if you go to any of the international meetings now, it gets very confusing because at each and every corner, there's again one more new map that's coming in. And by the time you know what that map does, there's 5 more that are coming. So it's fantastic. So pretty soon we won't have chemotherapy. We'll be treating all with monoclonal antibodies, which is exciting time ahead. If we look at how the NCCN guidelines suggests that we treat relapsed refractory ALL for a pH positive, there's a whole series of dasatinib, imatinib, ponatinib, till you can look at each and every new molecule coming through. So that's kind of like an exciting era. Of course, the CAR T cells are there and various newer ways of combining old drugs. So it's like a recipe. You still have the same basic condiments and ingredients, but we are learning how to combine them in exciting and newer ways to treat our patients. But we also have newer agents, and this is what I was talking about. And if you look at either B cell or T cell, there are various number of newer agents coming through. I'm just going to not go about all of that because I think if we look at that list, we probably would spend the whole day here looking at each and every one of them. And just say let's discuss 2 agents only. One, Clofarabine, which is already with us here, and each and every company is coming to us saying that we have Clofarabine. How do we use it? And of course, the second molecule I'm very excited about is Nelarabine. So talking about Clofarabine first, it's kind of new. It has been around for some time. It was approved in 2004 and it's a second generation purine nucleoside analog and acts as an antimetabolite. The main reason for its development was basically to overcome the limitations of cladribine and fludarabine, which is the dose limiting neurotoxicity, and have the best actions of both. Mechanism of action, I'm not a biochemist, so I can't pretend I understand this. Better? So I can't pretend I understand this too well, but as you can see, that what the drug does, it inhibits the ribonucleotide reductase, inhibits DNA synthesis, finally leads on to cell death. But looking at the first studies that came through, so this was in 2004, the initial dose finding phase 1 studies in adults and pediatrics. And very quickly we found a maximum tolerated dose about 40 milligrams per meter square in adults and about 52 in pediatrics. What was interesting is that in the ALL population, they found a response rate of 24% in the pediatric and 15% in the adult population, which obviously meant that this was a good agent for us to take forward in our whole armory of what else can we do for our patients with ALL. And this was one of the first studies that came through in 2006, where it looked at Clofarabine monotherapy in relapsed refractory ALL. This was again a Cox study called CLO 212, which looked at pediatric patients who had a second or a subsequent relapsed refractory ALL, and they received Clofarabine at 52 milligrams per meter squared over 2 hours daily for 5 days. Courses were repeated every 2 to 6 weeks. So again, it looked at toxicity, it looked at how well they respond, and looking at overall remission. Secondary objectives were duration of remission and PR. And what was interesting is if you look at that small chart right at the top, even in that group, they found almost a 20 to 30% response. The response rate was durable enough for a majority of the patients to proceed for a transplant, and that's what we are looking for in many of our relapse resistant ALLs, that can we take them to a transplant with some kind of a good holding chemotherapy. So next came that we have seen some results with monotherapy. Let's try combining it with other agents and see if we can improve upon the results that we had. And this was the COG CLO 218 study, where initially they went through a dose finding study of increasing the dose of clofarabine from 20 to 30 to 40, etoposide 75 to 100, and increasing cyclophos from 340 to 440 till they reach the end, which is basically where they came upon the same thing using clofarabine with these two drugs in pediatric patients with relapsed or refractory ALL with clofarabine of 40, etoposide of 100 and cyclophosphamide of 440 given every day for 5 days. That was a 5-day induction and a 4-day drug regime in consolidation. And again looking at the similar endpoints to see how these patients do. Most of these patients were heavily pretreated, having received 2 to 3 or they were already refractory at the time they came in. And even in this heavily pretreated resistant group of ALL patients, the results were fairly impressive. If you look up there, we are getting between 30 to 44% response rate in these very, very resistant patients. So the conclusion was that with this combination of these 3 drugs, it shows a good efficacy relapse and refractory patients. And in fact, 3 out of every 4 patients that were tested after this protocol had become MRD negative, which as we talked about a few minutes ago is a fantastic result for us to take them for a transplant. Now, Locatelli in Italy kind of did something very similar, but in a typical Italian way, he had to change the doses slightly. So, it decreased the cyclophosphamide dose, increased the etoposide a little bit more and went with a clofarabine of 40, looking at the same outcome, same endpoints. And in his series, 52% of his patients achieved CR. 76% with the B cell ALL had CR to complete remission, and in fact even some T cell patients responded well to the treatment. What was interesting was the last line, that some of his patients who were Philadelphia positive had also obtained complete remission with this regime, and the 18 months overall survival was nearly about 40%. So this kind of has become more or less standardized as a good regime combining these 3 drugs. UK published their results a few months ago, a couple of years ago, and they looked at slightly different combination of using clofarabine with cyclophosphamide only, and they showed a response rate of nearly 61%. They had responses both in T and B cell lineages in all age groups, and even in those with bad cytogenetics, with good response rates going up to 61%. I'm just going to say that this, to me, looking at all these results over the last 2 nights, looks like a promising new therapy. It's effective, it's well tolerated even in the very pretreated group, with a response rate that's reaching kind of 60%, even if you don't believe the 67 to 70% that has been reported in some groups. In this group of patients, anything that goes above 50 is a good agent. So we are seeing this in T cell, B cell adverse cytogenetics, and it's most effective when it's given in first relapse, but even in the second or third relapse, there is activity of this agent. Quick word about the dose, method of administration, really quite important to give a proper antiemetic. Patients can develop capillary leak syndrome, so patients do need prophylactic steroids. Important to avoid concomitant drugs which can cause hepatic or renal toxicity. And these are the usual adverse reactions that has been reported, and they are kind of the usual ones that you would expect from any kind of stronger chemotherapeutic agent that we use for our patients. I'm just going to put up a couple of other indications which are interesting. So one is this paper where they tried clofarabine in AML as a single agent, and what was interesting is that even in this condition we had an overall response rate of 26%. This has been duplicated by the COG, which ran a AAML 0523 study where they looked at clofarabine with cytarabine in AML patients and found an overall survival rate of nearly 46%. The doses are up there, but this again in AML patients we are getting good response. I was very interested at this study where they look at clofarabine in a completely different disease group. We are looking at Langerhans histiocytosis, Rosai-Dorfman. Now these are diseases in which, to be honest, we don't have very good chemotherapeutic agents at all. And if you're treating LCHS in your practice, you know that after if your patients don't respond to the frontline therapy, your second line options are fairly limited. But even in this group of patients, it's a small study, but you've got a 61% complete response. So it's a fairly exciting agent. And this third paper, which was a few years ago, which looked at yet another different condition, which is relapse refractory aggressive lymphoma. 16 patients, sequential therapy with clofarabine reinduction followed by a RIC transplant showed a 1 year progression free survival of nearly about 60% with 70% alive at 2 years. Why am I talking about these patients in a presentation on ALL is because if you talk about clofarabine, I'm really interested to see that this agent has got good action not just in ALL, but this is probably a drug that we'll be using in other conditions at some point soon. The second agent that's quite interesting is Nelarabine. It is a rationally designed drug that is designed to target the T cell ALL. It's a pro-drug that gets converted to ARA-G, approved in 2005 only for patients who have failed two frontline therapies. However, and I'll come to that it's actually now moving more and more to frontline therapy for T cell. That's the mechanism of action, which is basically ARA-G gets incorporated into the DNA and inhibits it, and that leads to cell death. So very early studies with this molecule, 93 patients were treated, adult and pediatric, escalating doses as we do with the first phase 1 studies, which showed significant neurological toxicity, but overall response in this very mixed group of patients showed that 31% response, but 54% response in that group was in the T cell group, which basically raised the whole question that is this a promising new agent for T cell. So the next phase 2 study was reported in 2005, which was a dose escalation study which went on till neurotoxicity, and in that also a CR rate of 46% was seen. What was interesting is that even those patients who had a CNS positive cleared it even before the intrathecal drug was given. So it actually penetrates into the CSF in a good enough concentration to neutralize and to kind of treat the CNS disease. So at that point it was approved for relapsed refractory T cell ALL, though it has got grade 3 serious neurological toxicity. These are the other major papers which looked at pediatric and adult patients, and most of these patients, as you can see, had failed at least 2 or maybe more prior therapies, and in that there was a little bit of dose finding arm in it where basically the dose was reduced to a dose that was actually tolerable. The pediatric and the adult regimes still are a little bit different. The pediatric regime is 650 milligrams per meter squared for 5 days. The adults believe in a 1500 milligrams per meter squared on days 1, 3 and 5. The overall responses has been grossly similar across both these groups. Adverse events basically, again, as we say, for most chemotherapeutic drugs are about the same, but with Nelarabine we need to watch out for neurotoxicity. The Germans checked whether they can use Nelarabine for T cells before taking them for a transplant, and they found with 47 patients with TALL a CR rate of nearly 47%, and most of these patients could be taken up for a transplant very, very quickly after being treated with Nelarabine. The COG was a little careful with Nelarabine. Like any new agent, what they decided to do was to take it fairly slow. And they said that if you have a good response to your PRED, so this is basically how it's coming into the front line. It's already there in a relapse refractory setting, and this journey is how it went to the front line. So they said that if you have a good response, sorry, I haven't got a, if you have a good response, then you're not going to get Nelarabine up front, but if you are MRD positive, that's when they would give these patients Nelarabine. And they kind of went into it a very logical way, where looking at doing BFM alone, then using BFM with the Nelarabine post-induction, then second half of induction and post-induction. Gradually, I just love the way they got it into each and every step, checking how these patients are doing on the regime. Till finally they said that we are going to use it in induction, reinduction and maintenance for T-cell ALLs. I'm not going to go into that. Others have looked into combination of Nelarabine with etoposide and cyclophosphamide. Very similar to how Clofarabine has been used. And in those patients also, data is out there to show that 71% of patients are achieving CR. Other people have used a continuous dose infusion, again based on cytarabine studies, which is well tolerated, and there is some mitigation of the neurotoxicity that we see. But this is the study, the COG-AALL0434, which is the most exciting study in Nelarabine. So the backbone is basically BFM. Cranial radiotherapy depends upon the risk group. There are two randomizations there. One is a randomization between a Capizzi style methotrexate versus a 5 grams per meter squared high dose methotrexate. And the Nelarabine is there on both groups. So this, do I have a pointer? Doesn't matter. Okay. So if you oh sorry, thanks. So doesn't matter. So basically, sorry, technology has defeated me. Oops, that's even worse. Upar ka. Got it. Okay, so we have a T cell phenotype, you have an induction, and post induction there's a risk stratification, which is our standard way of treating ALLs. After that, if you have a low risk, you get randomized to whether you get a Capizzi or a high dose methotrexate. You do not get Nelarabine if you are low risk. If you have an intermediate risk or a high risk, you get randomized to either Capizzi or a high dose methotrexate, and you also get randomized to whether you receive Nelarabine or not. So fairly complicated regime which goes down 1, 2, 3, 4, 5, 6 pathways. So it looks at two questions. It looks at whether Capizzi is much better than high dose methotrexate, and it looks at whether adding Nelarabine to both these arms in intermediate and the high risk has made a huge difference. So this is what we are talking about. You're randomizing between Capizzi high dose methotrexate for the intermediate and high risk, where you receive or not receive the Nelarabine, which is the 5-day at 650. Now, being a BFM based protocol, they obviously love their radiotherapy, which means that everybody receives prophylactic radiotherapy. If you have a positive CSF, of course, like anybody else, you'll give them therapeutic radiotherapy. Now, if you have a T cell ALL with an induction failure that you haven't actually entered into induction, then they non-randomized assigned them all to the high dose methotrexate, because at that point the supposition was that high dose methotrexate is better than a Capizzi. So if we look at the results, and these were the results that were just published, well, final results came out in ASCO 2018. Huge number, almost 2,000 children accrued over a 7-year period, and basically the first thing was whether it's safe and whether it's feasible. That publication came about 3 years ago, and they said yes, it's certainly very safe. So the initial concerns that Nelarabine causes a lot of neurotoxicity, it's an agent that we need to kind of avoid completely, has been shown to be not quite right, that if you are careful enough, it's an agent that we can actually use. The disease-free survival is the interesting bit. We are talking about T-cell ALL, and you're reporting a disease-free survival of 90%, which is fairly stunning. Third, definitely Capizzi style methotrexate is superior to the high dose methotrexate, and that's also fantastic. ETP ALL outcomes are identical to non-ETP. So the adverse effect of having a ETP has become negate by this protocol. Uh, MRD more than 1% is able to identify patients, which is standard, which is nothing new in that. So this is when we look at Nelarabine in the arms, it says that when you use Nelarabine, we have an 89%, none, it's an 83. It's about a 6%, and that's what's coming through in each and everything. I won't go through those in details, but just basically I'll take you to the final verdict that it improves disease-free survival in children and young patients with T-cell ALL, and they kind of say that it should become the new standard of care for TALL, and that's going to be my talk. Thank you. Okay, so to be honest, there's just one patient that I was trying to get it. I think we all were involved in that patient a few years ago. Unfortunately, that's only just one manufacturer for it, and at that time we looked at it, it was 25. So I think till we have a few other manufacturers coming through with it, we'll have to wait a little bit. I'm not sure because I mean, to be honest, I was looking at how many papers and what's out there. I think it has a role. I would not give it up completely. I mean, to be honest, if you ask me which agent I'm more excited about at the moment, I'm very excited about Nelarabine.
Nelarabine is what is showing more promising results.
I,
And
correct.
in comparison is now
Yeah, but
taking a
backseat. But I mean, I think Clofarabine, in its, to be fair, it's kind of a Me Too drug. Yeah, so it's somewhat similar to Cytarabine, but the combination of the three drugs that we have of Clofarabine, etoposide, cyclo seems to have a very good result. Now, I haven't used it. I don't know whether anybody's used the combination. I think it's new. So till we start using it, we don't know. Nelarabine is again completely new for us, and we need to use it and see how we get.
There's no question that Nelarabine is very good, but what that paper shows, 1,895 patients, is all T-cell ALL.
Yes.
So we still get 80%, 75% cure rate with conventional treatment. So we must remember that, I mean, in a select situation, maybe Nelarabine will be useful, but how much ever exciting the response is, but we still can cure 75-80% with conventional treatment.
I think it's certainly a good agent in a relapse setting, and it's exciting. It's coming on into a front line.
Yeah. Santanu, very nice presentation, but I agree with Girish completely that, adding something, I'm not very sure is really adding to very good improved survival. But, for the relapse TALL, one thing which is which may come in forefront in the years to come is daratumumab, which we presented in one of our BMT meetings. Now, daratumumab is used for myeloma. CD38 is positive in many of the TALLs, and we recently reported in BMT the first report of daratumumab in 2 transplants failed,
Yeah.
And the patient achieved MRD negativity. Jacob Rowe was here for an EHA meeting, which Dr. M.B. Agarwal conducted a few months back. In fact, I wasn't there for that meeting, but he said that the Jensen guys have got it in the wrong indication. Probably they should be looking at TALL. So that's something which is probably a very good drug, available already in India, and the European countries are already trying it in relapsed TALL. So that's one drug which probably will maybe make a difference, and of course the toxicity is manageable with that too.
I'm just going to very deliberately stop the discussion here because I want the CAR T-cell talk to start now. I'm really waiting for that, so please.
just increased the burden of expectation. So don't expect a very exciting